Thank you. So today we'll talk about factor V Leiden, and I have no conflict of interest to report. Any opinions and views expressed during this presentations are mine. So as I mentioned, we'll talk about factor V Leiden, how it is relevant to pharmacogenomics, the medications that can be impacted by factor V Leiden, such as combined oral contraceptives, thrombopoietin receptor agonists, and specifically Eltrombopag, because it is relevant to our case. A little bit about Nicklaus Children's Hospital. It's a 307-bed specialty hospital exclusively for children. So it's standalone pediatric hospital. It is a resource for children from South Florida and around the world, mainly South and Central America and the Caribbean region. We have approximately 800 attending physicians, including more than 500 pediatric subspecialists. The health system also includes Nicklaus Children's Hospital Foundation, a network of nonprofit outpatient and urgent care centers situated in 4 counties, a nonprofit physician practice subsidiary, and an ambulatory surgery center. The hospital implemented in-house inpatient pharmacogenomic testing in fall of 2023, so just last year. So now we jump into some didactic presentation about factor V Leiden. F5 gene provides instructions for making a protein called coagulation factor V, and it is essential cofactor of the blood coagulation cascade. So it is, when factor V is activated, it creates a clot formation to prevent excessive bleeding. And activated protein C is supposed to inhibit this coagulation cascade to prevent excessive clotting, to prevent excessive and prolonged clotting. Mutations or defects in the gene can result in either excessive bleeding or excessive clotting. And today we'll talk about thrombophilia, that excessive clotting. A little bit about pathophysiology. So there is that amino acid substitution at when arginine is replaced by glutamine. It's a single point mutation, and when that happens, the activated protein C cannot bind that readily, and what happens is that the activated protein C cannot work as fast, and the clotting is prolonged. It cannot really inhibit clotting cascade. So we have prolonged clotting, and the clots could be larger. Factor V Leiden is autosomal dominant with incomplete penetrance. So we need only one allele for it to be a disorder, a disease, but however, not all people who have that disorder will exhibit any symptoms throughout their lifetime. So it is estimated that between 3 and 8% of people with European ancestry carry one copy of the gene or the mutation, and about 1 in 5,000 people will have 2 copies of mutation. So people who have one gene, who are heterozygous, will have a lifetime risk of thrombosis by about 5 to 7-fold, and the homozygous, which is very rare, will have could have up to 20-fold increase chance of thrombosis. But again, not everyone who is a carrier will or have both genes will develop symptoms in the lifetime. The most common presentation of factor V Leiden is deep venous thrombosis. It is a lot more frequent than pulmonary embolism. Frequently, pulmonary embolism is the result of deep venous thrombosis. However, it can also occur without the DVT. Cerebral thromboembolism is also can also be presented, and it's more frequent in people who smoke and people who are on combined oral contraceptives. Less frequent presentation is Budd-Chiari syndrome, is when it's there is portal vein thrombosis, hepatic vein, and some other unusual places for clotting can also be a symptom for factor V Leiden. Arterial presentation is very uncommon and a very slight association, if any. And there are different guidelines, and it's a risk factor for complications in pregnancy, during delivery, and postpartum. In general, screening and testing for factor V Leiden is not recommended because it is considered expensive, it is rare, and the clinical management wouldn't change with DVT or any other thromboembolism, regardless if person has factor V Leiden or does not. Factor V Leiden is usually diagnosed with genetic testing. However, there is a functional activated protein C resistance assays, but even with that assays, genetic testing is usually chosen to confirm the condition. When it comes to commercial panels, some of them will test for factor V Leiden and other panels will not. So it depends on the company and if they choose to put it on the panel. Sometimes factor V Leiden is a separate test a lot of the times. And now we'll talk about how factor V Leiden is affecting certain medications and how it is relevant to pharmacogenomics. So combined oral contraceptives, there are guidelines that the medications are not recommended in women who have non-thrombogenic mutations such as factor V Leiden, because there was observed a 2-fold to 20-fold risk of thrombosis in women who use combined oral contraceptives and have factor V Leiden. The condition represents an unacceptable health risk if this contraceptive method is used. However, again, routine screening is not appropriate. Another class of medications that has PGx actionable implications is thrombopoietin receptor agonists, and currently there are 3 medications approved by FDA. The oldest is Eltrombopag. It was approved in 2008. There are other 2 which were approved in 2018. And all of these medications carry a warning to consider the potential for an increased risk of thromboembolism in patients with known risk factors for thromboembolism, including genetic thrombotic conditions, which is factor V Leiden. When it comes to PGx evidence and guidelines, so a European Medicinal Agency, FDA, and Canada Health have actionable PGx annotation for factor V Leiden. For CPIC level, it's level C and it's provisional status. And PharmGKB level, it's 1A for contraceptives and no current level of evidence listed for Eltrombopag. So now a little bit about Eltrombopag, because it is the medication that will be in our case discussion. So I'll use the proprietary name Promacta. So it is thrombopoietin receptor agonist, which is indicated for treatment of thrombocytopenia in patients with chronic immune thrombocytopenic purpura who have had an insufficient response to corticosteroids, immunoglobulins, or splenectomy. Promacta should be used only in patients with idiopathic thrombocytopenia purpura whose degree of thrombocytopenia and clinical condition increase the risk of bleeding. Promacta should not be used in an attempt to normalize platelet counts. However, off-label, it is sometimes used to normalize platelet counts in oncology patients undergoing chemotherapy. It's an orally bioavailable small molecule. It induces the mechanism of action. It induces a proliferation and differentiation of megakaryocytes from bone marrow progenitor cells. It is extensively metabolized by oxidation and glucuronidation. So both phase 1 and phase 2 are involved. It inhibits mostly phase 2 enzyme and some transporters. And however, the significance of this inhibition wasn't evaluated in the clinical studies.